are you here? Yeah.
Yes, sir. I'm honored to introduce our dear colleague Maria Cardoso from Lisbon, Portugal, speaking about avoiding unnecessary oncoplastic breast surgery. It's quite interesting to listen to that. So you have the coming 20 minutes. Thank you.
Thank you, Omar. Are you seeing the screen?
Yes.
Yeah. Okay, so let's see if it works. Okay, so thank you all for inviting me. It's a great pleasure to be here. And I only don't think Bahadir because this team is really difficult. Okay, so this was a really, really difficult challenge. Okay, it's not working also. Let me just try again. Okay, not working.
You can use this slideshow if it's not giving the full one. Yeah,
I know.
Try again. If it doesn't work, then just.
I will see. Yeah.
That's great.
Okay.
Yes, it's working.
No conflicts. And it's quite difficult to talk about oncoplastic breast surgery because for many years, breast surgery was taken out of the platform of interest for general surgeons. So it was mainly mastectomy, axillary dissection, then came breast conservation, and it was considered to be not technically challenging. And then oncoplastic surgery came, and it became a fashion, and it is a fashion. People like to tell us that they do a lot of oncoplastic surgery. And I tried to make this presentation interesting for everybody, trying to extract the main message that I think are important for all. So reviewing what we have is defining the definition of oncoplastic surgery and the outcomes. And that's where we have some evidence. But the really interesting stuff with almost no evidence is who needs what and how to decide, and implications of patient tumor, team factors on the type of surgery that will be chosen, and what really is unnecessary. So the background is every patient undergoing breast surgery deserves to have an ideal oncological outcome that's easy to measure, and the best aesthetic result possible. And that's where things start to get complicated, because that can be what the patient wants or what we consider to be good. So that gets more difficult to evaluate. Regarding the definition, the vast majority of definitions regarding oncoplastic surgery refers to breast conservation only. Then we have the broader definition that I like most, that includes also mastectomy and reconstruction, all types, and the need to obtain symmetry with the contralateral breast. Just to show you how many definitions there are in oncoplastic breast surgery, you can see this review from the American Society of Breast Surgeons, where they finally came to a final definition. And if you look at the inclusion of breast conservation, techniques of displacement, replacement, mammoplasty, mastectomy, symmetrization, and also defining the levels, you have a confusion of definitions all over all these authors, still more, that leads us to a sort of what are we talking in real. So the Americans define at this consensus of the American Society of Breast Surgeons that breast cancer surgery, oncoplastic breast surgery, will mainly be referred to breast conserving surgery, incorporating an oncological partial mastectomy with repair by volume displacement or volume replacement, and when needed, contralateral symmetry surgery when appropriate to the other breast. This is very important because at the American Society of Breast Surgeons, they include this definition in the reimbursement of this type of surgeries. Then we have the opposite European, and we have the consensus that Albert Walter Weber promoted, where the questions to the panelists define that oncoplastic breast surgery was mainly referred to breast conserving surgery and replacement techniques, mastopexy and mammoplasty reduction. And then we have the UK definition that applies to every type of breast surgery, from breast conservation to mastectomy, with every type of reconstruction and symmetrization of the contralateral breast. And this is very important because this is how we define what is necessary and unnecessary. For the purpose of time, I'm not going to be able to talk about everything, so I decided to focus on oncoplastic breast conservation surgery. So I'm not going to talk about mastectomy, although I think that mastectomy and reconstruction are part of the armamentarium of breast surgery. So what we have regarding the comparison of breast conserving surgery, what we call the historic breast conservation surgery, and oncoplastic breast surgery. What is the available evidence? In general, the available evidence is poor. We have underpowered studies, we have no randomized trials, and we have a collection of prospective studies with systematic reviews and meta-analysis. But this has happened a lot in surgery. So we start doing things before we have results, and then it's quite impossible to go back. So just to get a little hint of what is detailed in this meta-analysis, one of the most interesting ones is the one by Losken from 2014, and you have here a total of 8,000 patients, 8,500 patients, and you have a division between oncoplastic and breast conservation, and then you have a division between reduction, replacement, and breast conservation. And what you see in general is you have more positive margins in breast conservation, like it was expected. You have more re-excisions in classic breast conservation, but you have more mastectomies in oncoplastic reductions. This was not strange at the time, and is still something that happens because it's more difficult to define the re-excision margins when you have an oncoplastic reduction. Then regarding satisfaction, recurrence, and complications, you have the tendency towards less positive results in breast conservation. Another meta-analysis, and this is the most recent one, it's a very confusing one because you have large series, you have more small series, you have comparison with oncoplastic and breast conservation, and then oncoplastic mastectomy and breast conservation. But mainly the idea is if you have oncoplastic breast conserving surgery, usually you have less need to go and have a new intervention, so more free margins, and you have a small percentage of recurrence. To take notice that the follow-up of these studies is quite small, and they are very heterogeneous. So we have other meta-analysis that I didn't show here that analyzes the heterogeneity of the studies, and is really very high. So to summarize, available evidence is poor. We have underpowered studies. We have no randomized trials. We have the prospective studies that offers the best available evidence, but summarizing, we have low rates of local recurrence. We have free margins in a huge percentage of cases. We have closed margins in some, but now we know that even in oncoplastic, no tumor or ink margin is the standard. we have positive margins in 9.4%, and this is a very recent systematic review, and they tend to undergo for mastectomy in 7%. Regarding cosmetic outcomes is very difficult because the majority of these studies don't evaluate cosmetic outcomes, and when evaluate cosmetic outcomes, the methods by which the cosmetic outcomes are evaluated are very, very heterogeneous. And you have here an example. So this is again a systematic review of 6,000 patients. And when you look at the difference, you have the main surgery that was done was therapeutic mammoplasty, but then the cosmetic outcomes are only evaluated in 1,000 of patients. And even in those, the methods by which the cosmetic outcomes is evaluated are very, very different from one study to the other. But now let's move to what is important. We need to go on. Oncoplastic surgery, although a fashion, is here to stay, and we use it with very, very interesting outcomes in many patients, and we have that evidence. So the important thing is who needs what and how to decide, what implications are all these factors, patient, tumor, treatment, and team, and what really is unnecessary. So the main message here is we know from all the retrospective data that we have now that breast conservation seems to be in early breast cancer, early stages, T1, T2, and 0, better than mastectomy. So breast conservation is possible. Tumor factors are very important. Patient factors also. So we have the breast size, doses, expectations, and hobbies. So all the things that the patient does. We have the radiotherapy, and Philip is there, and we have many problems in oncoplastics. So like we all know, radiotherapy has a diversity of options nowadays. So besides the whole breast, we have boost or no boost, we have partial breast radiation, and we have the new fast schemes. So it's very important to understand how these new techniques will interact with surgery, and then we have the reimbursement. So I'm not going to detail a long time in this slide. All of you know that the last results show that breast conservation in early stage breast cancer seems to be better in terms not only of disease-free survival, of overall survival, but also in disease-free survival. And this seems to be supported by the larger fields of radiotherapy when compared to all the cases where mastectomy was done without radiation. We have a myriad of options, from simple with local flaps, therapeutic mammoplasty, latissimus dorsi, mini flap, perforated flaps, fat injection, implants, whatever. And there are a huge amount of algorithms that will help you to get a hint on how to decide which is best for these patients. Giuseppe Catenuto is there. He has a very, very interesting decision tool for deciding which thing to do. I think, to be honest, when you are not experienced, it's very important to have a support. When you are experienced, all these questions that are introduced in algorithms are coming out in the discussing with the patient, because it's so obvious how you're going to do it. So these are the factors that I really talked about. So you have all these, the patient factors are very important, and they are the center of the decision. And don't forget that what's minor for us can be major for the patient. And now it's where we don't have any evidence whatsoever. So I show you here 3 situations, and these patients were all proposed for breast conservation. And it's clear for us, we don't know the patients, that the patient for me in the left, the one with the larger doses, will benefit from a therapeutic reduction mammoplasty. The one in the middle that is very small breast, but she has a small tumor that is hormonal responsive, but is in the superior inner quadrant, could go on some kind of surgery, maybe trying neoadjuvant hormonal treatment. And the third patient also could have a breast reduction. But the third patient, she likes the breast that she has. She has a very complicated breast to do a reduction mammoplasty because, as you can see, the axis of the breast is completely displaced. So just to show you, I'm not going to play with examples, but the patient in the middle wanted to look nicer with bigger breasts. So we had a breast conservation with implants, and you can see in the right side a capsular contracture after radiotherapy. The patient in the right had reduction mammoplasty, and the patient for me in the left and now in the right had also a reduction mammoplasty with reposition of the axis of the breast, but then the breast reduced a lot after radiotherapy. And I'm just showing one of my conflicts of interest, saying that we need to go further. And I'm sorry for all those that are expecting to start this trial because the pandemic really delayed the trial that is called Cinderella. So Cinderella wants to use artificial intelligence and the patient options to try to have a more standardized approach for what the patient wants. So the idea is to have a huge database of breast cases where we can show the patient the best and poor result of the surgery she wants to have according to her body mass index, age, etc., etc. And she can look at the results and decide if this type of surgery is the one she wants to have. And then we're going to mix in a artificial intelligence algorithm to try to get to a final result that will help us to decide at the presentation. But one of the things, and we have Philip there, and I always want to have a radiation oncologist by my side, because one of the things that made oncoplastic surgery in the last 2 years more difficult is how radiotherapy changed. And this is very important, and I'm going just simply to show you some examples. So this is a patient that had these breasts, and she has a 2 centimeter grade 2, and 3 nodes were positive. And we decided, and these positive nodes were detected intraoperatively, although she had a normal ultrasound. A normal ultrasound in more obese patients sometimes is difficult. And she decided she didn't want to have a reduction. I talked to her about the idea of radiotherapy and the importance that big breasts have on the effect that radiotherapy has. And you can see the result at the end. And this patient suffers from severe pain, and we are going to need to do something because she has a miserable quality of life. Another thing that is very important is these mini flaps, and here you have the muscular flap, but you can have the TDAP flaps, the LICAP flaps, whatever you want. And this is a very interesting paper talking about the boost when you have replacement techniques, because, and Philip is there and he can correct me, they talk about the rim boosts. You don't need to irradiate the muscle, you don't need to irradiate the skin, the dermis, and adipose tissue fat, because otherwise you are going to have a flap that disappears. And this is what happened in this patient several years after, because results will deteriorate. So you need to talk with your radiation oncologist to know how to do it. Another thing that is very complicated is the idea that clips that you put in a breast reduction are going to be very easy to delineate for radiation oncologists. And you see here, this is a study from Canada showing that the tumor bed boost that is evaluated in a phantom after oncoplastic surgery is completely displaced. So when you're talking about partial breast irradiation techniques, and you need to discuss that with the patient, you need to think about the oncoplastic surgery that you are going to propose. Another very important thing is reimbursement, And I strengthen the effort that this group of authors did to write this manifesto. And one of the sections is about oncoplastic surgery. Many countries in Europe don't have reimbursement for symmetry purposes, for other surgeries for improvement. So we need to think about that, because then patients are stuck in something that they can pay. And this is the work of our colleagues in Germany that is exemplary. So you have a code for reimbursement. In my country, we don't have anything like that. So it's very complicated to have reimbursement. So to finalize, important clues. Surgeons must never drive an idealized aesthetic goal at a very vulnerable moment in the woman's life. It's very important because we are enthusiastic. We want the best for the patient and we want to give her the best, but we need to hear the patient. We need to explore a real expectations. Patients may accept a smaller, simple operation and further small aesthetic reinterventions. Today, perfect symmetry is not going to be like that in 5 or 10 years. That's for sure. Index breast is frozen in time with radiotherapy. So sometimes it's much better with radiotherapy, but the other one will drop, will change, will fat, will get slimmer. Those are the important clues in quality criteria. I'm not going to read about that. They are published in the quality criteria for oncoplastic breast procedures at the Association of Breast Surgeons with a joint venture with the British Association of Plastic Surgeons. And there are several things that are very important. To evaluate your results, you need to register, you need to take photographs before and after to see the results. What is really unnecessary, and I finalize with this, to push for something that you think will be better. The important thing is what the patient wants. To raise expectations without taking into consideration the poor results of your own series. To make assumptions that will not be considered by third-party payers. So it's easy, but it's not going to be paid for. To take decisions outside the scope of the MDT. So always discuss, and nowadays this is very important. Patients sometimes want to trade 5 days of radiotherapy for a very complicated surgery. And simple breast conserving surgery still can and should be used in a high percentage of actual patients. Thank you so much for your attention, and I'm open to questions also.